So may I call the next speaker for the next talk? It's postprandial hyperglycemia, heightened role of premixed insulin. And for this we have Dr. S K Sharma with us. Sir needs no more introduction. He is well known from DM endocrinology from PGI Chandigarh and presently endocrinologist at Galaxy Specialty Center Jaipur, and has many of the publications to his credits, and as a speaker in various national and international forums. And so over to you, sir.
Thank you. Thank you. I'm thankful to Dr. Sameer and his party for inviting me here. Thank you to chairpersons. And my job is to look into postprandial hyperglycemia and how we can manage it with pre-mixed insulins. So dear friends, this will be the flow of my content. We will be looking at the unique characteristics of Indians, particularly looking into the Indian diet and how the postprandial glucose load is more in Indians as compared to Caucasians. What are the risks of having very high postprandial glucose level, and whether we are using insulin late in the natural history of our type 2 diabetic patient, some take-home messages, and then we will be having a case where we will be looking into how the pre-mixed insulins are helpful in the management of that patient. So looking into Indian dietary habits, you can see here that this is a famous STAR study which looked into the composition of our diet, and you find that we Indians are eating too much of carb, and here you can see the 64% of calories are derived from the carbohydrate diet, and our patients are not adhering to the dietary request, and we somehow are not able to reduce this carbohydrate content to something like 50 to 55%, and this will lead to more of postprandial hyperglycemia. On the other hand, we are having some system in our body that if you compare ourselves to Caucasians, we have more postprandial hyperglycemia. And we all know that if the HbA1c of our patient is to be looked into, which is contributed by both fasting as well as postprandial, what we used to say that if the HbA1c is very high, it is mainly contributed by fasting hyperglycemia, and you have to fix the fasting first, what we say, and basal insulin was considered to be a good option there. But here if you look into our patients, you find even if the HbA1c is very high, the contribution of postprandial is very high as compared to the fasting hyperglycemia. So somehow we Indians eating same type of food, but our postprandial goes very high as compared to the same food which is eaten by a Caucasian. So now looking into the risk of this postprandial hyperglycemia in the management of our diabetic patients, you find that uncontrolled postprandial hyperglycemia may lead to so many complications in our patients. It causes increase in macrovascular disease, it increases the intima media thickness, it increases the you can say oxidative injury, causes impaired early diastolic dysfunction, decreases the myocardial blood flow, and increased risk of complications like retinopathy, and increasing the pancreatic cancers in our diabetic patients. So peaks of hyperglycemia leads to endothelial injury, and that may be a cause for more of you can say setting up of plaques in the future, and these patients are having more of cardiovascular injury. If you look into this slide, you find that if you look into that particular glucose level, fasting glucose level is similar, but the postprandial is in one patient 140, in other 140 to 199, in other it is more than 200. So fasting is same, but the postprandial is rising, and the mortality of these patients who are having very high postprandial blood glucose is far higher as compared to those who are having lower postprandial. So somehow our patients are having that type of scenario where the postprandial is going something like 100 milligram above the fasting level, and that is causing more of not only cardiovascular events but also death of these patients. So postprandial glucose is independently is a marker of mortality in our diabetic patient. Now looking into how you will achieve HbA1c, if you are mainly emphasizing on fasting plasma glucose control, 64% of your patient will be having good control of HbA1c, that is less than 7. But if your patients are having good control of postprandial, that is if it is 140 or less, then 94% of your patient is going to achieve a HbA1c of less than 7, indicating again that postprandial is having more contribution in decreasing. If you are decreasing postprandial, your HbA1c decreases to a greater extent as compared to fasting plasma glucose. So control of fasting hyperglycemia is necessary, but usually insufficient for achieving HbA1c goal of less than 7, and control of postprandial hyperglycemia is essential for achieving recommended HbA1c goal. And because we in India are using insulin very late, so are we starting the insulin at right time is a very important question. And you find that intensive treatment with oral anti-diabetic drug is effective for some years, but we keep on increasing 1 drug, 2 drug, 3 drug, and then we avoid giving insulin. There is a great level of inertia there. Both patients as well as sometimes physicians are afraid of using insulin. There is a block there, what we call inertia, and then it leads to long duration of hyperglycemia, and it causes all those chronic diabetic complication, whether it is microvascular or macrovascular complication. Hence, a timely initiation of insulin becomes a very imperative, and reducing the future risk of developing complications of our diabetic patients. And if you look into these studies, where you find that the insulin was initiated only once the HbA1c is more than 9, 9.4, 9.9, only then insulin was introduced. We all know, once the type 2 diabetic patients are having 2 drugs or maximum of 3 drugs, giving the 4th drug will lead to a HbA1c reduction of 0.2%, not more than that. So somehow we are delaying insulin initiation, and if you look into these different studies, you find HbA1c is very, very high in these patients. And if you look into one of that study, that is IMPROVE, and looking into the 4 corners of India, you find that whether you are looking at south, north, east or west, you find that our patients are having very high HbA1c to the tune of 9.4, and you find that HbA1c levels are very, very high in this region all across India, and difference between the fasting and postprandial is something like 100 milligram. So this, what we expect is something like 50 milligram or so. So if the person is having 100 milligram of fasting and 150 of postprandial, we say he is having a good control, HbA1c will be something near at 7. But here you find that the postprandial is significantly higher, and there is often a delay in initiation of this insulin therapy, resulting in higher risk of failure of basal insulin. Why basal insulins are failing here? Because most of them are having postprandial hyperglycemia. Basal insulin was very effective once you are having a fasting hyperglycemia, which was seen in the early part when the patient was having a HbA1c deterioration in the first few years. But now you are delaying insulin so that basal insulin is not able to control both fasting as well as postprandial, and thereby we see, as compared to West picture, where the insulin is given at an earlier age, earlier stage of the disease, here you have giving basal insulin which is failing, because you may be able to keep on increasing basal and bringing fasting to the target. But what happens here? Your postprandial remains high. So that's why the role of pre-mixed insulin comes in here. So the convenience and simplicity of pre-mixed insulin along in our patients, in our physicians' mind is very, very good. So it is easier to start. You can start these pre-mixed insulin once a day. You can up-titrate or intensify the treatment twice a day. And there are studies where they have given these pre-mixed insulin 3 times a day also. So if you look into recommendations by different bodies, you find most of them are saying that you should start initiation of insulin with basal insulin, like ADA, ACE, IDF and Canadian guidelines. But here what happens, once the doctor writes, most of the patients are following those instructions, and fear of insulin is a bit less there as compared to our type of scenario. NICE guidelines say you can start basal or you can start premix, and RSSDI again highlights that you have three choices: basal, premix, or you have co-formulations, where again a type of premix is there where you have short-acting and long-acting insulin combined together. So these are some of the recommendations. But why basals are failing? As I explained, that basals are able to control only fasting hyperglycemia, and our patients are initiating insulin very late, and that's why we are not able to achieve postprandial control. That's why our HbA1c of our patients remain higher. So in the summary of this part of my talk, you can see there is a significant contribution of postprandial glucose even when the HbA1c is higher. What we expect, higher fasting, but here higher postprandial glucose is there in Indian population. Premixed insulins are simple to start, and with a single injection once a day, and then you can up titrate it to twice a day, and rarely we are giving it 3 times a day also. Patients who are uncontrolled on 2 or 3 oral antidiabetic drugs, you find that they can be started on premixed insulin, which appears to be convenient and easy to manage. Premixed insulin provide convenience and simplicity at initiation of, you can say, start of therapy as well as titration of therapy. And premixed insulin provide both convenience and efficacy to the patient and contributes a long way of achieving good glycemic targets. So looking into the role of premixed insulin in our uncontrolled type 2 diabetic patient. Here you have a patient who is a lady of 52 years, history of type 2 diabetes for the last 12 years. Most of the things are similar in most of our patients. HbA1c of this patient is 9.3, fasting 146, but postprandial is 255. She is having most other things which are under control. And she was taking 3 oral antidiabetic drugs, sitagliptin 100 milligram once a day, glimepiride 4 milligram divided into 2 milligram into 2, metformin full doses of 2000 in one day, and then you see that her HbA1c was not controlled. So here is the scenario where we can use HbA1c to be controlled, and you find that choosing a premixed insulin here is a good choice. You can see here that the glycemic factor which tells us that we can choose premixed insulin is a postprandial increment of more than 54. So if the fasting is 100 and postprandial is more than 54 above the fasting, then probably you need a premixed insulin which will target both fasting as well as postprandial. There is another way of looking at it, that fasting ratio of fasting to HbA1c. If that ratio is less than 20, indicating that fasting is not very high, but HbA1c is very high. So HbA1c is high because of higher postprandial. That's why you have this type of scenario. You can use premixed insulin. And here again, one more indicator that if the bedtime glucose and the morning glucose level between the two is more than 55, then again you require a premixed insulin given before dinner of this patient. Psychological factors, again, you find that it is simple to operate and very easy to titrate. Phases of the life. So if the patient is having shorter duration of diabetes, your basal insulin will work for few years. But if he is having long duration of diabetes, what we see in the Indian context where insulin is delayed, you find that your HbA1c will not be coming to target with fasting. So here HbA1c will be in target after a mixture of premixed insulin. And then there are patients who are elderly or who are having poor, you can say, understanding, where you can explain this thing that you have to give 1 insulin injection per day, and if not controlled, you titrate the same insulin twice a day. Usually once we give twice a day, we are using this insulin pre-breakfast and pre-dinner. Here I want to just have a indicator here that these are the types of patients which we see in our outdoor patients. In type 1 diabetics, we never use premixed insulin. We are the basal bolus therapy, 4 insulin injections, 1 long-acting and 3 short-acting are to be recommended. It is unfair to use type 1 diabetic patients, treat them with premixed insulins twice a day. So that is absolutely clear. Patients of your type 2 diabetes who are very sick, who are having multiple comorbidities, or who are in your ward or who are having comorbidities and you want tighter control or during pregnancy, these are again the patients who require basal bolus therapy. But these are outdoor patients where they are on some oral antidiabetic drugs and you want to add insulin because your 2 or 3 oral antidiabetic drugs are not able to control hyperglycemia. So with that, premixed insulin provide control of both fasting as well as postprandial glucose, along with the convenience of initiating, titrating and intensifying. So here you find this lady was given, you can see here a study is there where they are comparing premixed insulin to basal insulin. So HbA1c reduction was better with premixed because you are targeting both fasting as well as postprandial, and number of patients who are achieving target is higher in patients who are having premixed insulin. You are having only one advantage of basal, that fasting blood glucose are well controlled with basal insulin, long-acting basal insulin, as compared to that postprandial, whether in the morning hour or in the afternoon or in the day, in the night time, it will be better controlled with premixed insulin. So better reduction of A1C and attaining a target goal within is good for premixed insulins. Again, overall hypoglycemia appears to be slightly more with premixed insulin as compared to basal, but the nocturnal hypoglycemia is slightly more with basal as compared to premixed. And again, you find so many studies comparing basal insulin to premixed, and here you have brighter red bars showing us that the HbA1c reduction was far better with premixed insulin as compared to basal insulin. And once this patient was started on premixed insulin, given let's say 10 units in the morning, followed for a few days, then it was given twice a day, and then you up titrated the doses, and ultimately she was on 22 units of premixed in the morning before breakfast and 16 units in the night time, and she was achieving a good control of hyperglycemia. So this is how we are treating our patients of type 2 diabetes in a outdoor setting where the patients are already on many other oral antidiabetic drugs. Here, once the patient is on single injection, we may continue with sulfonylurea, but we are always continuing metformin, and if the patient is on DPP-4 or SGLT2, we don't stop them with insulin initiation and continuation. But if the patient is on 2 insulin injections or probably 3 insulin, probably no role of sulfonylurea there, so you usually withdraw them and you continue with metformin and if possible DPP-4 or SGLT2 inhibitors, and you will find that these 2 injections of premixed insulin with some of these oral antidiabetic drugs in our type 2 diabetic patients are going to achieve good control, easy to manage. Thank you very much.
Very nice talk by a very experienced teacher. Before opening the debate for the friends to intervene, I just want to comment that inertia of not using insulin is lying with the physicians. Many a times we people start, we are inhibitive in even talking about insulin with the idea that patient भाग जाएगा, भाग के कहाँ जाएगा? A के पास, B के पास, and if his sugar is not controlled, will come back to you. वो कहेगा सर आप अच्छे थे, आपने ठीक कहा हमारे को. This is one. Secondly, in Haryana at least, people are most of the time they are taking good food twice a day. So what I recommend to my patient is 50-50 premix insulins. In spite of 30-70, 50-50 will be better idea.
Absolutely. That is absolutely right, sir, because they are eating only 2 meals. So their postprandial will go very high because they are avoiding lunch. They are eating something like 10, 11 and in the 7, 8 in the evening. So, and their meal is good.
Yes, stuffy food. Yes.
So 50-50 will be taking care of the carbohydrate content of that meal.
Dr. Sonika?
Yeah.
Anybody want?
There are no more questions on behalf.
There is question.
You want to know?
Mike, please.
Mike dena bhai.
Yeah, please.
Let people listen.
Sir, I'm a resident in medicine. So the problem with twice daily mixed art is that mainly the peri-lunch meals are technically uncovered.
Yeah.
So we often feel that the evening time rise or the before dinner values go haywire, mainly because of the lunch snacking. It's uncovered with the rapid acting insulin. So how do you deal with that?
As I told you that in type 2 diabetic patients, we are taking help of some drugs also, oral drugs also. like we are giving metformin, we are giving DPP-4 inhibitors in addition to this. So one is that help from the oral antidiabetic drugs. And then of course there will be a rise in postprandial after lunch if the patient is eating a good amount of lunch. Some amount of basal component of the morning dose of premix will remain there, but it will not be sufficient if the meal is good in amount. So either you have options of giving a small dose of short acting in the covering the lunch, or if this type of patient has, Dr. Sabha highlighted that only eating twice a day, those are the absolutely correct patient, I should say, for this twice a day premixed insulin.
So this twice daily meal, is it, it's not physiological, so is it healthy for the patient? So we modify the diet according to that?
Absolutely.
Or we tell the
we always say that small frequent meals, 3 major meals, 3 minor meals in a diabetes is good. You are absolutely right. But still many of our patients are going to the office, they eat at 10 and then eat at 7 or 8, something like that. So in that type of patient where the timing of the meal is fixed, amount of meal is more or less fixed, these premixed insulins are doing good job. But where the lifestyle is very, very erratic, on one day the executives are not eating at the right time, on other day they are eating very late in the night. In that type of patients, I think flexibility of basal bolus is very good, that you are covering the every meal whenever you are eating, and then you have a basal insulin in the night time. Yeah.
Thank you,
Thank
sir.
you.
Thank you all the speakers, and we conclude the session. Thank you.